Thank you, Lisa. That was wonderful. Thank you, Aggie. It's so great to see so many of you. What an incredible community that we've built together. So my ask today is to give the annual update on pancreatic cancer, which I have given for the last few years. But this year I titled it Progress and Hope, because I think that there's been so much great progress that's happened over the last year or so that I'd like to share with all of you. Just a few disclosures. What we're going to cover today is how pancreatic cancer is changing, how we diagnose and personalize treatment, the current treatment options, new and emerging therapies, and where I think the field is going. So what's new this year? Well, between last year and this year, when I gave you the update last year, there's been development of more treatment options than ever before. Genetic and tumor testing now guides care for all patients, and we recommend that genetic and tumor testing be done on everyone because it can affect treatment. There's hot new drugs that are targeting KRAS that are showing early success. There's cancer vaccines that are in development, personalized, and they're moving forward in advanced phase trials. And immunotherapy is starting to show promising combinations. The vaccines are a type of immunotherapy, but these are all treatments that we didn't even talk about 10 or 15 years ago at all. So as I said, genetic testing it's standard of care. It's recommended for all patients with pancreatic cancer. There's two types of genetic testing that you can have. One is what's called germline testing, and the other is somatic or tumor testing, and we'll review both of those. But it's really important that you get it done because it helps guide treatment decisions, it helps guide clinical trial options, it helps determine family members' risks of developing pancreatic cancer. So this is all a key part of personalized care. The two types of genetic testing are germline versus tumor testing. So that germline testing is what's inherited. Those are all cells in your body. We can do this by a blood draw or just by a swab of your mouth. These are the genes that are like BRCA, that are like for Lynch syndrome, that are like P53, which can be mutated, and they're passed down in families. And this can identify inherited cancer risk, as I said, risk of family members, but it also can help us guide treatments too. So it's essential that everyone newly diagnosed with pancreatic cancer get that germline testing. And then there's another one called tumor testing or somatic testing that needs to be done with a sample of the tumor. That we can use tissue that's gotten with an endoscopic biopsy or a surgical resection or even potentially a percutaneous biopsy of the liver. And these are the changes that are found only in the cancer. This is like where that KRAS gene shows up. They're not inherited, and they're the mutations that happen that cause the tumor to develop. But this is ever more important today than it was before, and I'm sure it'll be even more important next year with the advancements that will happen over the next year or so. But it helps us identify those treatment targets. Takeaway, both are important and provide important and different information, but it's important that you get them. So here's a genetic landscape of pancreatic cancer. On the right there, the columns are patients. The rows are different mutations that happen in those patients' tumors. And they develop progressively as the tumor starts to develop. The precursor lesion to the cancer is called a PANN or pancreatic intraepithelial neoplasia. These are akin to like colon polyps or polyps in the colon. Unfortunately, they're not detectable. can't see them on CT, MRI, endoscopic ultrasound. They can only be seen microscopically, which is what's handcuffed us a lot in diagnosing pancreatic cancer at an earlier stage, is we can't really detect or see the precursor lesions. But we do know from analysis of them and ones that have been removed surgically, the mutations that are present in them, and the mutations are progressive mutations that happen that go from a precursor lesion to a cancer. And that KRAS mutation is one that happens early. It's called a founder mutation. It's present in those precursor lesions, and then as the lesion progresses, you get progressive mutation like the P53 and other genes that can happen. But that KRAS is present in 95+% of pancreatic cancers. So as I said, it's important to get tumor testing, it's important to get germline testing, because this slide summarizes how we kind of think about things now. On the left there is standard chemotherapy, which we'll review. But then we ask ourselves, is KRAS mutated? And what specific mutations are present in KRAS? Because now there are drugs that target specific mutations in KRAS. And so we want to know what the profile of your tumor is in order to match you up with a specific drug that targets that mutation. Very few patients have KRAS wild-type tumors, which you can see there, 4 to 8%, but we're interested in other mutations that might be present in these tumors that have different therapies that can target those mutations. And then on the right there, as I said, this is the germline testing where you can see BRCA1 or 2, and we know specific chemotherapies and we know specific targeted therapies that are more effective in patients that have these germline BRCA mutations. So this is kind of how we think about things. And at the outset, the first question is what does the germline profile look like, and what does the somatic or the tumor testing profile look like? So again, why it matters, and I keep emphasizing it because it's so important, and we can help you here get your germline tested, we can help you here get your tumor tested. We do this routinely on all of our patients now. But identifies patients who may benefit from those targeted therapies, helps match patients to clinical trials, provides information for family members, and increasingly influences treatment decisions. What about blood-based testing? These questions come up a lot now too. There's so many more assays that we can do with blood samples than we were able to do before. And this can be divided into two categories. One is screening and one is monitoring. So screening, blood-based screening tests, that's like the GRAIL test you've probably heard of, or the Galleri test that's being increasingly done. And that's looking for cancer early. This is used in people without a known cancer, so it's a screening test. It looks for signals of cancer in the blood. It can detect some cancers, including hard-to-detect cancers. That GRAIL test or that Galleri test, the final readout was a little bit disappointing. It didn't show reduction in detecting late-stage cancers. It was about equivalent. So this is very promising. These assays are being refined. There are several of them. They're not ready for routine use. And when patients ask me about them, I oftentimes tell them, we're still collecting the data to realize the accuracy of these tests. So those are screening tests, like the GRAIL test, the Galleri test, and these are patients without cancer. So blood-based testing, what about monitoring? So these are patients that have cancer, pancreatic cancer, for example. And this is now tracking known cancer. And this is what we call circulating tumor DNA testing. And so used in patients with a cancer diagnosis, tracks tumor DNA over time. It detects, we can accurately monitor responses to treatment, may identify recurrences earlier than scans. You can have tests that are informed by the mutations in the tumor that are thought to be potentially a little bit more sensitive. And it's a useful tool to monitor disease over time. So this is a whole new thing, the monitoring, the blood-based circulating tumor DNA monitoring that we were not doing 2 or 3 years ago routinely. But now we're using this routinely to monitor patients responses to therapies. So how do we monitor the cancer over time? How do we monitor how you're responding to the treatments that you're getting? There's the circulating tumor DNA that we talked about that detects tumor DNA. It can provide direct information. And then there's the good old standards like CA 19-9 and CEA that are commonly used. They're helpful. They're not perfect, but we now have this circulating tumor DNA to help us to monitor your response to treatment and your cancer much more accurately than we were able to do before. So these tools are complementary. But yet another thing in our armamentarium to help treat you and monitor how you're responding to treatment. So how do we treat pancreatic cancer today? The treatment depends on the stage of your tumor, your health, your overall performance status or your health, and the biology of your tumor, how aggressive it looks like the tumor is or not aggressive. We take that into consideration too, and personalizing your treatment and determining what treatments are best for you. And our main approaches are surgery, chemotherapy, targeted therapies, immunotherapy, and then there's radiation therapy. So chemotherapy still remains the backbone of treatment of pancreatic cancer. The most common regimens that are used are, I'm sure most people in this room know that, FOLFIRINOX, which is what we call a 5-fluorouracil-based regimen, 5-fluorouracil, or FU, and it's called FU for a reason. There's gemcitabine and nab-paclitaxel, or Abraxane, is another commonly used regimen, one that has really been established largely due to the work by Dr. Tempero, who's here and will speak after me. There's Nalirafox, which is a variation of FOLFIRINOX that was a positive phase 3 trial that was led by Dr. Zev Weinberg, who's in our group here. But those are the most common regimens of chemo. There's many, many more, but these are the most common ones that we use as the main backbone. There's some emerging regimens. There was a combination therapy called PAX-G, which is cisplatin, Abraxane, and gemcitabine that was tested in a small study in Europe that showed a signal, and so there's going to have to be a larger trial with that, but that's one area of excitement over the last year where I think that the combination chemotherapies, the options have expanded. So the goals of the treatment or the chemo are to shrink the tumors, control the disease, and improve survival. Treatment's becoming personalized, right? Not one size fits all. And as I said, our treatment is increasingly guided by genetics, by patient goals, by tumor behavior, and we take that all into consideration. Fortunately, here at UCLA with the Hirshberg Center, we have an integrated practice unit where there are not only all the medical professionals there from surgery, medical oncology, radiation oncology, but we also have professionals, experts from supportive services like nutrition, like psychosocial services, like genetic counseling, and others who can help with your treatment. Because the treatments have become more effective, because people are living longer, we're talking about things like maintenance therapy now. And so those are the treatments that we have to transition into to maintain the treatment of your tumor and keep it repressed. And also talk about treatment sequencing more than we did before. Here's one study that's caught a lot of attention that's been developing over the last 2 years or so, and I'll tell you why it's really important. So it's called the EXTEND trial. And this is patients with a small number of metastatic disease, so tumor spread from the pancreas to the liver. But it's kind of a new paradigm in pancreatic cancer. And the approach was to treat with chemotherapy and also to give a local therapy to those metastatic tumors. And so the old approach was to give chemotherapy in patients with metastatic disease. But what this introduced is a concept where we're now starting to think about not only treating systemically with chemotherapy, but also focusing on and targeting those metastatic lesions and treating them locally too, either with radiation, ablation, other methods like surgery or local therapies. And in this small initial study, patients who got the local therapy had a longer time before progression. So there was a 4 times improvement in progression-free survival, and there was a trend towards improvement in overall survival. So the take-home message there is now that our systemic treatments are getting better, we're starting to think about local treatments, even for metastatic lesions. And this is an emerging strategy in very selected patients, but now they're expanding this to a phase 3 study called the EXPAND trial to really test this hypothesis or approach and see if it's better. This is that EXTEND trial here that I just described to you. So stage 4 pancreatic cancer patients, less than or equal to 5 metastasis. They were randomized to standard of care chemotherapy or standard of care chemotherapy plus the local therapy or the metastasis-directed therapy. And you can see on the right there, the patients in the red curve, this is their survival curve for progression-free survival, had a longer survival if they had those metastatic lesions treated too. So still to be determined, but some excitement about treating the metastatic lesions locally. Okay, KRAS. Let's talk about KRAS. So a major area of progress for pancreatic cancer. So found in 90+% of tumors, this was long considered undruggable, but that has changed. So now there's new drugs in phase 3 clinical trials, registration trials, which is about to get them FDA approved, showing really exciting early signs of response. And so I think the future is going to be combination therapies with these RAS inhibitors. So I said KRAS present in 95% of pancreatic cancers. This is the distribution of the specific KRAS mutations that are present in pancreatic cancers. So unfortunately, there's not a ton of them, and they all happen at 3 sites in the KRAS gene. So these areas can be targeted. This slide shows all the different therapeutics that are being tested now to directly and indirectly target KRAS on the right there. So many trials going on, so many molecules that are being tested, a lot of promise here. So new KRAS targeted therapies. So targeting KRAS directly. There's 2 main approaches to talk about. First are the pan-RAS inhibitors. So these inhibit the mutant form of KRAS and also the wild-type form of KRAS, which is present in all of your cells. And so it has more side effects, these pan-RAS inhibitors, than the targeted KRAS mutant inhibitors. But this was the first drugs that were well developed, and these are the first ones that are being tested. They're furthest along on the pipeline. With a lot of promise. So broad coverage, most patients, because they're pan-RAS inhibitors. So you don't have to get matched up for your specific mutation as long as you have a KRAS mutation. Early but encouraging therapy. The one that's the most advanced is daraxonrasib from Revolution Medicines. And in the initial study, so they took patients who had been treated with other regimens before and then gave them this drug, and there was a 35% response rate. They also tested it as a first-line therapy, so patients who had not received treatment before, a 55% response rate, so great response rates, and this was even stronger when they combined it with chemotherapy. They currently have 3 phase 3 clinical trials that are ongoing, testing this drug either alone, either in combination with chemotherapy, either in combination with a targeted KRAS inhibitor, so combined pan-RAS and mutant-specific KRAS inhibitor, and even considering a new study giving it to patients after surgery, so not just in advanced stage disease. So this is not just promising, but it's, I think, on the verge of becoming standard of care. This is a slide with the responses in patients who received this pan-RAS inhibitor, and the bars that are below the x-axis there are all patients who had a response to the drug. And on the right there, you can see with the arrows On the left, the baseline, this is one patient who had tumor metastasized to their lungs. And then on the right there is after they were on treatment where the metastasis to the lungs completely melted away. The other are the mutation-specific inhibitors, and this is why, in addition to the pan-RAS inhibitors, but this in particular is why it's so important that we do your genetic tumor testing, right? Because we need to know the KRAS mutation that's present in your tumor to match you up with the specific inhibitor. So this is what's called precision medicine or precision targeting. And these mutant-specific inhibitors have been proven in lung cancer, and they're really emerging in pancreas. The examples here are two drugs that target G12C mutation, and then another one that targets a G12D mutation in pancreatic cancer. G12D is much more common than G12C. But these have a really high response rate with chemo in patients with pancreatic cancer, and being tested in phase 1 and 2 trials in combination with the pan-RAS inhibitor or with chemotherapy. I think over the next year, these are going to quickly move to a phase 3 or even a registrational trial, and we'll be talking about that next year. So KRAS 2026, critical regulator of pancreatic cancer. There's now targeted therapies, there's pan-RAS therapies, so many drugs emerging to target KRAS. And these, as I said, I think will be part of a backbone of therapy for pancreatic cancer moving forward. Okay, what about immunotherapy? This is another hot area of focus now. Immunotherapy works well in some cancers, melanoma, renal cell cancer, kidney cancer, not as well in pancreatic cancer. And that's because the tumor is really good at blocking the immune system. But we're trying to bypass that and circumvent it and get around it with new strategies that are emerging. These are combination therapies with immunotherapies. We're very excited here at UCLA about targeting adenosine. We have a clinical trial where patients are treated before surgery with an adenosine inhibitor, which is a type of immunotherapy. The anti-tumor vaccines, which we'll spend a couple minutes talking about, and also cellular therapies you've heard of, like CAR T cells, which are very early on. So tumor vaccines. So you think about vaccines for infectious diseases like COVID or other viruses or other bacteria. This is a very active area of research and trials for cancer and pancreatic cancer. There's different vaccine classes, so it can either be a protein, it can be a viral vector, it can be mRNA. mRNA is the class that was used for the COVID vaccines. We learned a lot from COVID about how the immune system responds to mRNA vaccines, and there are some in development now for pancreatic cancer. So these personalized cancer vaccines, the personalized ones are made from a patient's tumor, and they train the immune system to recognize the cancer, like they train the immune system to recognize an infectious disease. And some early results from one trial, which I'll highlight, is they generate a strong immune response, delay in recurrence, and there's larger phase 3. Phase 3, so that's the last step before something becomes approved. Clinical trials ongoing. This, the main vaccine work, or the first place to really start doing this for pancreatic cancer was at Memorial Sloan Kettering. And this was based on some science that a surgeon there did, who found that patients who survived a long time, when he looked at their blood 7 years out, so 7 years out from having surgery for pancreatic cancer, and those long-term survivors, when he looked in their blood, he found T cells that matched T cells or immune cells that they found in the surgical resection tumors. So those patients, the presumption here is the patients who responded longer generated a really good immune response and a long-term durable immune response. So moved into thinking, how can we try and generate this with a vaccine? And this is that personalized vaccine. This is the phase 1 study. It's now in a phase 2/3 study, which we have open here at UCLA. But take out, so these are patients who underwent surgery, so their tumors were removed. They were sent over to Germany to BioNTech, which developed one of the COVID vaccines, and they were analyzed to find the specific mutations present in the tumor, and then they generated a vaccine to target those specific mutations. And as I said, about 50% of the patients responded or generated an immune response to that mRNA vaccine. And the recurrence-free survival in those patients who generated, the 50% that generated that immune response has not been reached compared to the patients who did not generate an effective immune response, who their recurrence-free survival was much, much shorter. A lot of promise, and as I said, now this has moved into a phase 2 study for patients after surgery. And this is something that we have ongoing here at UCLA. So clinical trials are absolutely critical. They provide access to new therapies, they help advance the field, and there's been a ton of advancements in the last year. Many of our current treatments come from trials, and so I encourage you to ask about clinical trials early. But the gatekeeper for all of this now is that germline and somatic tumor testing to see which ones you'd be eligible for. So standard therapy, 2026. Chemotherapy, I talked about the regimens, FOLFIRINOX, gemcitabine, Abraxane, NALIRIFOX, this new PAX-G regimen. As I said, we're thinking about maintenance therapy now because people are responding so well, and it's a lot to ask someone to undergo multi-agent chemotherapy for a long time, and you don't need me to tell you that one. And building on the standard, right? So targeted therapies, immunotherapies, actually thinking about local treatment of metastatic disease or tumor that's spread to the liver or other areas. So key takeaways and why we're optimistic. Treatment is improving. Genetic and tumor testing are now routinely done and they're essential. New therapies are emerging, those KRAS-targeted treatments, immunotherapy combinations, vaccines like we talked about. Clinical trials are expanding options for patients. There's so many more now than there were even a few years ago. And so there's more progress and hope than ever before. So that's why I titled the talk today, Progress and Hope 2026. So thanks again for your attention, and happy to take any questions.
I'm not used to being told I might not be heard. I guess I have a couple of questions. The first one is, for the ctDNA testing, is that done here at UCLA, and are there any locations you know of in Washington State that do it?
They're all sent out. Most are sent out, the ctDNA. Signatera is the main one that most people use, but these are send-out tests, and so your oncologist or the oncologist you're working with should be able to know about that.
Okay, so those can be ordered anywhere and then sent to the relevant place.
Absolutely.
And in my situation, there's KRAS wild type, or my family's. How do you have that kind of picture of the evolution of different genetic mutations? Do you have a sense of what that looks like without starting with KRAS?
Yes, we do. As I said, 95% are KRAS mutant, but the other mutational profiles are pretty similar to the KRAS mutant tumors. I actually talked about that last year. So I refer to you my talk on the website from last year. I took the slides out this year. There are other targetable mutations that happen in patients that have KRAS wild type tumors.
Thank you.
Sure.
I have a question about the personalized vaccines.
Yeah.
Will they ever be approved by the FDA if they're only treating one person? And if so, how will it be scalable?
Yeah, it's a good question. I mean, this is a really complex topic. They will be approved by the FDA if the readout is positive in the phase 3 study. And the scalable question is a good one. So this personalized approach is labor intensive, challenging. As I said, we have to send it.
Expensive.
Yeah, expensive. It's really hard to generate or identify mutations in tumors that we call immunogenic or the immune system responds to. But there's so much work being done now to generate kind of catalogs of them and to match that with off-the-shelf vaccines. And you also have to know the patient's HLA haplotype and how these mutations are expressed on the cell surface. So it's a really complex thing. We're going to need, obviously machine learning, artificial intelligence to help with all of this. But where things are going, I think, in the future is to have off-the-shelf vaccines that could be matched by catalogs or repositories of effective mutations that are identified in patients, that we need some kind of computer to help us match all that up together.
I'm in the process right now of having a vaccine designed and manufactured for me, and it would be nice to be able to see this available to everyone and not people that really can just afford it.
Yeah.
And I think the concern is the scalability and how it would be able to treat everybody and not just me in my case.
Yeah, absolutely. Yeah, that's a big challenge.
Hi, I'm asking for a friend. Is pancreatitis
You're a good friend.
Yeah, I am.
Yeah.
Is pancreatitis a precursor for pancreatic cancer?
It's a good question. We think that chronic inflammation of the pancreas is bad, and that can lead to cancer developing. Most patients who develop pancreatic cancer don't have really a history of having any symptoms that could be attributed to chronic pancreatitis. So it's usually like some kind of low-grade smoldering inflammation of the pancreas that does not cause symptoms that is oftentimes the precursor to pancreatic cancer. So yes, chronic inflammation is bad.
Thank you very much.
Of course.
I've got a question about the Extend program you talked about. It would be chemotherapy and another technique like radiation. Would that be done concurrently at the same time, or would they be done one after the other, or in any kind of order?
So usually we start with what we call a full course of systemic chemotherapy. So that's like a 6-month course of treatment. And in patients who respond well to the chemo, but still have some residual tumors in the liver, the lung, or elsewhere, that's when we start thinking about now, because of this Extend data, start thinking about targeting them locally with radiation or ablation or something like that. So it's usually the full 6 months at least of chemo, then the consideration of the local therapy with potentially some kind of chemo at the same time, and then some kind of maintenance therapy after that.
Okay,
but not till a first full course of systemic chemo.
Hi, I have a question over here.
Hey.
Hi. I'm hearing conflicting information on mutations. Can the mutation change, or if you have a reoccurrence, can it ever be changed? Some are saying yes, and some are saying no. So I'm not sure.
It can absolutely change. These tumors are smart. There's a set of mutations that are called founder mutations, that are the ones that occur early, and those usually persist throughout the whole cancer time. But you can develop progressive or additional mutations that can develop over time, and so that's why I think it's important to even potentially, test your tumor at several points during your treatment, not just once at the beginning. Because if you've been on a treatment, say, for 6 months, 9 months, a year, and that treatment stops working, it may be because the tumor has developed additional mutations that's causing it to be resistant to the treatment that you're given. So yes, have it tested more than once if it's clinically indicated.
Okay, and one other question is, I saw on your slide it said now enrolling for a trial that was up there. Do you have any recommendations on how to get into a trial?
Yeah.
Because that is a really hard
It is.
situation.
There are so many promising, Dr. Tempero can probably talk about this even better than me, but there are so many promising trials now and drugs and treatments that are being tested, it can be hard to find a slot for patients just because, we're like saturated, we're full. But I think that's why it's important to get treated at a place like here or UCSF because, that's where we're really good. We have a, really big portfolio of clinical trials that where you'd have more options than treated at a place that doesn't have as many resources.
Okay, thank you.
Of course.
Hi, Dr. Donahue.
Oh, hey.
Hi.
How are you?
I'm gonna. I just have a quick. That was one of my questions,
Voice came out of
actually.
my head, yeah.
How do you get into the trials and the clinical trials? But my specific question from your talk today is, I'm a G12V girl, and you mentioned D and C. What specific drug is being tested for G12V beyond the pan-RAS? And where are they doing those trials?
I don't think there's a specific G12V inhibitor. No. Good. Dr. Tempera is shaking her head no. Yeah.
So G12V folks, the only thing they have is pan-RAS.
Pan-RAS.
Got it.
Pan-RAS.